Okay, hi everyone. As people are coming in, I think we can open this GNN meeting, which is the last webinar of the year. And I will turn over to Mario Melgar, the GNN chair, for the introductory remarks. Over to you, Mario.
Thank you, Luis. And it's very nice to have you all here today. As Luis said, this is our last webinar of the year. You can find the draft agenda of the GNN meetings available on the NITAG Resource Center. You should know the link, but Luis will put it in the chat so you can find it easily. Also, just to let you know that a survey was sent. We would really appreciate you replying to it. We would like as many replies as possible, at least one reply per country. If more is better. And this will help inform for the SAGE meeting in March. And we're going to start our meeting for today. We have Rocio presenting. She works in the polio research policy and product development team at the WHO, and she's part of the secretariat of the bOPV cessation group. So we go to Rocio for starting our meeting.
Hi, Mario. Thank you. Are people able to hear me?
Yes.
Yes. Okay. Thank you so much. Thank you. So I'll guide us first through the agenda. We will have three main sections in the presentation. So first up will be an update on polio epidemiology, immunization coverage, and surveillance. This will be presented by myself and colleague Alejandro Ramirez-Gonzalez. He's part of the EPI team of the IVB department. That's immunization, vaccines, and biologicals. And then next will be a section on the revised Global Polio Eradication Initiative strategy timelines. This will be presented by colleague Zubair Wadoud. He's in the laboratory surveillance and containment team at WHO HQ. And then the final section presented by myself will be on the bOPV or bivalent oral poliovirus vaccine cessation policy framework and the general planning from the bOPV cessation team. And then we'll hand over to you, Chair, for wrap up and closing and start of the discussion. So we can begin into the first portion of the presentation, which is on the status of polio epidemiology, immunization, and surveillance. I'll present the first part on the polio epidemiology and surveillance, and then hand over to Alejandro to present on, on immunization. So to start off, here's a quick snapshot of the current polio eradication strategy spanning from 2022 to 2026. So the strategy has two main goals that are the focus. So goal 1 centers on wild poliovirus type 1 or WPV1, and goal 2 centers on circulating vaccine-derived poliovirus type 2 or CVD-PV2. And so the current strategy for goal 1 set that WPV1 interruption of transmission was set for end of 2023 with certification of eradication by end of 2026. And the last isolate of CVD-PV2 for goal 2 also reported by end of 2023 with the validation of absence of CVD-PV2 by 2026. So as you can see, the program is off track for both goal 1 and goal 2. And so in the next section presented by Zubair, the strategy extension and the revision of the strategy will be walked through. So first, to preface that poliovirus circulation, both of wild-type poliovirus type 1 and CVD-PVs, continues to be declared a public health emergency of international concern since 2014. So it is just almost over a decade now. And so here is a global map of poliovirus isolates in 2024. And so this is to sort of document this progress against goals 1 and 2 of the GPEI strategy. And so to sort of go through the legend here, we have in circles are the clinical paralytic cases, and in squares are the environmental wastewater positive isolates that have been detected. And so to begin, in red are the isolates pertaining to wild poliovirus type 1 or WPV1. So these are concentrated in the two remaining endemic countries, Afghanistan and Pakistan. There have been 84 paralytic cases to date in 2024, compared to 12 in the same period in 2023. Then pertaining to CVD-PV2, apologies. So then pertaining to CVD-PV2, those are the green dots across. There have been 221 cases of CVD-PV2 in this year. This is a decrease from the same period last year, where there was 395 cases in 2023. So as you can see from the map, there continues to be mainly transmission in the Lake Chad Basin countries, and then also to note this primarily to be in Nigeria and Yemen. There have also been detections in a list of countries, including Angola, Benin, Cameroon, Chad, DRC, Ethiopia, Guinea, Indonesia, Liberia, Mali, Niger, Palestine, Senegal, Somalia, and South Sudan, and more recently, several environmental detections across several countries in the European region. To note, there is co-circulation of type 1 and type 2 CVD-PV in DRC. So then moving to CVD-PV1, there have been detections in DRC and Mozambique, but to note a very positive development is that there have been no isolates of CVD-PV1 from any source in Madagascar, which is a very positive development, as this has been a historic reservoir for CVD-PV1. So in total, there have been 10 CVD-PV1 cases in 2024 compared to 134 in the same timeline in 2023. And then finally, to note in purple, the isolates for CVD-PV3, where there have been several environmental isolates in French Guiana, and recently several paralytic cases in Guinea, where there is outbreak response currently underway. And so to look more specifically into sort of a timeline of isolates in each serotype. So here we have a focus on WPV1. So it spans from 2016 all the way to present day of 2024. So this top row looks at the paralytic AFP, which stands for acute flaccid paralysis cases related to polio. And then here on the bottom are the environmental isolates. And here, just to draw your attention that there has been a stark increase in environmental positive sample detections in the last months. This is sort of due to reestablish transmission in historic reservoirs. And to recall, there's only WPV1 transmission in the 2 endemic countries. And to highlight here that the situation is complex due to various socioeconomic, political, and accessibility factors, which Zubair will go through in more detail in a later section. Next, this is the epicurve for CVD-PV2, again from 2016, where to note here is where there was a switch from trivalent to bivalent oral poliovirus vaccine in routine immunization schedules. And so this is a sort of trends from 2016 again to 2024. So after the switch, there was this increase in both cases and environmental detections. But since 2020, where we experienced a peak in global cases, there has been a steady and onward decline in CVD-PV2 cases. And so again, here to note that there are several geographies that particularly northern Nigeria and eastern DRC, that continue to be core reservoirs of transmission. And then finally, to look here on the CVD-PV1 in purple above and CVD-PV3 below, detections for CVD-PV1. Again, just to highlight that there has been no CVD-PV1 cases in Madagascar for over 12 months now, which is a very great achievement. Also seeing that sort of downward trend once again. And this year there have been detections in DRC and Mozambique. And then finally for CVD-PV3, there have been a few environmental detections in French Guiana, and then also some recent AFP cases in Guinea. And so here's just sort of a key sort of message and to note of general characteristics of population and geographies that sort of have these persistent or experience this persistent transmission of poliovirus outbreaks. And these are sort of some characteristics that are ubiquitous to these areas and population. Of course, they sort of highlight some of these main challenges. They're not all that are experienced in these geographies and populations, but just to highlight first a persistently low routine immunization coverage. So there's sort of a higher proportion of under or unimmunized children. Then also to consider insecurity, conflicts, and difficulty of accessing certain high-risk populations, whether it be due to political instability or if there are multiple humanitarian emergencies which sort of compete with the vaccination network services and the performance of the Global Polio Eradication Initiative. And then finally, which this could result in some operational and quality gaps of the program, and to just highlight these sort of persistently missed children in supplementary immunization activities. And so highlighting here the importance of routine immunization coverage, I'll hand over to Alejandro to present the next set of slides on immunization. Thank you.
Thanks, Rocio. So just to complement what Rocio sort of presented, I will cover a few slides on the routine immunization, starting with the global estimates, the WHO UNICEF estimates for IPV1, which is the sort of first top map. And here you can see that, I don't know if you remember previous maps or updates, but it's a fairly similar picture than in previous years. We can see like a small and a big area of low coverage in Africa, then Southeast Asia, and also this year in South America. In terms of the countries, the specific countries, you can see the ones in deep red color. So these are the countries that are below 50% coverage for 2023. And I think important to note here is that these countries are actually the same countries as 2022. So I think we can consider that these countries have a very significant immunization gap for type 2, at least from the routine immunization perspective. So these are actually quite concerning. On the endemics, you can see Pakistan and Afghanistan. So Afghanistan continues to have quite low routine immunization, I mean IPV1 coverage, and actually decreased slightly from 2022 to 2023. And Pakistan, while the coverage is higher, it has also decreased from the previous year. So this is also that needs to be, looked into, and these countries should increase their coverage. The other map on the introduction or the implementation of the IPV recommendation, the 2 doses of IPV in routine immunization programs. We have 33 countries that are still needing to introduce the second dose, and half of these countries almost are in the African continent. So this is something that we are working very intensely with these countries to advocate and see these countries introducing the second dose of IPV. Next slide, please. Yes, so this continues to look at the global estimates, but together with our colleagues, our data colleagues in IPV, in WHO, we try to go deeper into the analysis. So here we present you with a couple of graphs, and it's basically what we're doing is separating the OPV using countries into 2 groups. Though the group on the right, or the graph on the right, is the group of countries that have circulation, CBDPV circulation, and then on the left-hand side you have the OPV using countries without CBDPV circulation. And then we compare DTP3 and IPV1 coverage, and what you can see is that the countries with circulation of CBDPV, they have a much lower IPV1 coverage, significantly lower. So while this is not sort of hard scientific evidence, I think might lead to think that countries with, or the lower the IPV1 coverage is, the higher the chance or the risk of CBDPV circulation. And also important to note here is that you can see that DTP3 and IPV1 are actually matching each other in both of the groups, in both of the graphs. So for those countries with CBDPV circulation, it's not only a matter of increasing IPV1. I think it's more like a systems-wide issue, right? Because I think they're providing IPv1 to the level they can, which is the DTP3 proxy. So I think these countries, we sort of need to be supported in strengthening their programs in order to increase the needed coverage. Next slide, please. Yes, I'm moving from coverage per se to zero-dose children, which is a metric that is monitored by the IA 2030 with the goal of reducing 50% the number of zero-dose children from 2020 to 2030. So here you can see the bars are actually the number of zero-dose children in million for the last 20 years. And then on the pale blue on the right-hand side is actually the goal of the 50% reduction. And then you can see the line that we actually need to track in order to achieve the 50% reduction goal. And you can see how off track we are and how we really need to change, something. We need how to do things in order to be able to achieve this goal if it's actually achievable at all. Next slide. Yes, so in order to address those coverage issues that I described and the zero dose, I think there is a lot of approaches that have been taken into put in place. From the polio perspective, I think we can. The milestone was the Polio Oversight Board approving the integration approach at the end of last year. And then since then, the program really pushing for integration activities in order to find program efficiencies, increasing coverage, and basically reducing the number of zero-dose children. Traditionally, I mean, the polio program was doing some of these things in campaign-based activities, but now also, as you can see at the bottom of the figure, is actually making a big push in health system strengthening. And I think polio program is actually working with EPI actors at regional and country level in order to, as I said before, try to increase or strengthening systems, implement the zero-dose agenda, participate and coordinate with the big catch-up activities, and also provide access to inaccessible communities. So I think these are the areas where the polio program is working with the other EPI actors. However, the polio program obviously sort of focuses on the consequential geographies in the endemic countries and lately on the big catch-up countries. So this is the areas where the polio program is collaborating. Next slide, please. And lastly, I just want to also introduce you to the new, the latest tool, the latest vaccine that we have in the polio immunization, which is the wholesale pertussis hexavalent that became available under Gavi support in December 2023, and then to be later pre-qualified by WHO in March 2024. The vaccine comes with expectation to deliver protection against the 6 diseases that are the 5 that are included in pentavalent plus the IPV in a more efficiently and in some cases more cost effectively. And of course, I think one of the areas, one of the challenges that we noticed or we faced in the past was the multiple injections and hesitancy towards receiving certain number of injections. So I think this is an area where the hexavalent comes with great hopes to reduce the multiple injections and increase uptake. We currently have 1 pre-qualified product only, but we expect additional products to be pre-qualified in 2026 and 2027, therefore increasing supply availability. That at the moment is becoming available in a gradual manner, and it will be driven by supply demand, at least until those 2 products are pre-qualified and available in 2026 and 2027. So far, we have got a very good response, great interest from countries, and so far the countries that are listed there as approved, these are the countries that were approved by Gavi, so they will be introducing or switching to hexavalent in 2025. The first country, I believe, will be Indonesia in Q1 2025, and the rest of the countries will progressively do so throughout the year. And also in conversations with regions and countries, we also have a number of countries showing strong interest to apply for support in the coming rounds of support. And this is not only for Gavi supported countries, non-Gavi middle-income countries are also interested, and as such, for example, Turkmenistan will also plans to introduce in 2025. Next slide, please. So I think lastly on hexavalent, and we have more detailed presentations on hexavalent, I mean, if you are interested, but just to basically mention some of the main considerations that we have with the hexavalent in the presentation that we have. So obviously, I mean, I described some of the potential benefits, and that's clear that there is some potential benefits, but countries have to keep in mind that the vaccine costs might be higher, especially if countries need to introduce the booster. So if they need to introduce 4 doses, the cost will be higher than the current Penta plus 2 doses of IPV. However, some of these additional costs might be offset by some of the programmatic savings or some of the programmatic benefits that are related to the fact that you will have to provide fewer injections, there might be a reduced workload, and there will be some cost savings throughout the supply chain. I didn't mention before, but the presentation that is available through Gavi support is a 10-dose presentation. The 1-dose presentation is at the moment only available for middle-income countries. So, for example, for countries that are using the 1-dose pentavalent, this needs to be taken into consideration as it will be a significant change. Also, in the planning and implementation, countries will have to stop the use of IPV, and probably, in some cases, they will have to introduce a booster. So this has to be planned nicely. So the transition period when the vaccine is introduced or when the switch takes place is smooth, and there is no missed children at the time of the introduction of the switch. Also, I should say that in terms of polio vaccination, both the 2 doses of IPV and the hexavalent are actually both equally recommended. So they're actually both good options. So it's important to mention that countries should not wait if they have not introduced the 2nd dose. They should not wait for hexavalent indefinitely or in the future. I think it's important that all countries introduce one or the other as a matter of urgency. And then, as I mentioned before, the programmatic aspects that are related to the 2nd year of life, so to the booster. So this also needs to be taken into the planning into consideration. Next slide, please. I think this is my last one. Yes, and these are just some of the resources. The first 3 columns, the first 3 blocks are for Gavi supported countries, the resources from the Gavi Secretariat. And then the last one is from WHO, UNICEF, some policy and technical documents. And also to mention that we are developing additional materials, so training materials for healthcare workers, and guidance, implementation guidance. So this will be shared with you or will be posted in the near future. Over. Thank you. I think it's Suber.
Thank you, Alejandro. I hope I'm audible. I was having some audio issues. So thanks very much to Rocio and Alejandro, and I'll try to just build upon where Rocio and Alejandro left. And just try to provide a brief overview of the recent revisions of the GPEI strategy timeline. Next slide. Okay, so just before I talk about the revision of the timelines, just to I think recall where are we coming from? Over the last 3 decades, tremendous effort to bring the program to a stage it is at now, with just 1 wild poliovirus type, which is endemic in one of the regions of WHO, with 2 of the 3 wild poliovirus types already certified as eradicated. So that marks a real tremendous progress, but definitely, things have come to a bit of stall in recent times, and that's because of, some some real complex challenges. So just in the light of ongoing program reviews, some internal to GPEI, but also advised by the Technical Advisory Group on Polio Eradication in Afghanistan and Pakistan, the two endemic countries, as well as bodies like Independent Monitoring Board. The Polio Oversight Board in its July 2024 meeting deliberated upon feasibility of meeting the timelines for both the goals. And here I'm talking about the goal 1. So just while these discussions happened, inputs were taken into account from the GPEI strategy committee and a few of the important working groups and focusing on the current challenges and current context that relate to operational and programmatic aspects of the program, but also certain contextual factors that relate to political situation in the endemic countries and outbreak affected countries, and that includes security and access dynamics that the program is operating in. For example, political transition in Afghanistan and subsequent dynamic situation in the country, and also evolving political landscape in Pakistan over the last 2 years or so, including the recent general elections. Next slide. Now, if we look at the situation in the endemic countries that were sort of reviewed and were considered while assessing the timeline's feasibility, it's clear that the epidemiology, which we witnessed in 2023, and you can see on the left-hand side map, is not the same as what we are witnessing in 2024, and is being showed here in the map on the right-hand side. And you may see both human cases, polio cases, as well as positive environmental samples for wild poliovirus type 1 have quite exponentially increased during this year compared to last year. And that's, as I said, due to a range of reasons, quite multi-dimensional challenges. Some recently emerged and others intensified, and that led to deterioration of this of the epidemiology, as you can see. Most of these cases and positive environmental samples this year were reported during the high transmission season between July and September. Now, we are seeing more and more difficult security situation to operate in Pakistan, including attacks on frontline health workers and their guarding security personnel. Also, factors like community boycotts in two important provinces for polio, KP and Balochistan, in demand for other health services, but also some broader development sector services, and using polio as a sort of a bargain chip.
Thank you so much.
We also recently saw that inability to perform house-to-house campaigns in South Afghanistan. That trait actually expanded to the entire country, with regression to site-to-site campaign in whole of Afghanistan over the last couple of months or so. And this actually constitutes a major risk for the gains made. And there can be further spread of poliovirus within Afghanistan, but also beyond. So that's the sort of context on goal 1. Next slide. Moving to goal 2. And as my colleague Rocio already mentioned, that although we have seen an overall decline in the number of CVDPV2 or type 2 variant poliovirus cases and outbreaks, however, the places that really are sort of driving the global epidemiology, especially in the African region, northern Nigeria, for instance, is still continuing to report cases as well as positive environmental samples. Eastern DRC is seeing a slight decline, but there are clear indications that low-grade transmission is continuing in DRC, and similarly in the Eastern Mediterranean region, South Central Somalia and Northern Yemen, the two consequential geographies, continue to report transmission and cases. Next slide. Now, zooming in a bit into the African region, and before I dig deep into type 2 CVD-PV, I'll just try to echo Rocio's earlier optimism about Madagascar that has not reported any detection of CVD-PV1 from any source for more than 12 months, which is a good news because Madagascar was seeing a really long-standing outbreak for several years, and this marks an important development which will be independently assessed during the first half or the first quarter of 2025, when an independent group of experts is planning to go and assess the situation in Madagascar to inform a potential closure of this outbreak. Having said that, when it comes to type 2, we are seeing Lake Chad Basin countries, especially Nigeria, with continuing transmission, in fact, intensifying transmission in Nigeria. Also the same for Horn of Africa, even outside Somalia, in places like Ethiopia that have seen intensification of transmission of CVD-PV2 over the last 6 months or so, which is a bit worrying. So on one hand, the numbers are going down, but on the other hand, the taps that are the source of virus over the last several years are continuing to have transmission, and that indicates a continued risk. Next slide. A bit of focus on the Eastern Mediterranean region, where continued outbreak in northern Yemen, and important to recall that no immunization response could be carried out in northern part of Yemen because of the local situation, difficult security and access. But just a recent encouraging development was in the form of a meeting with local authorities of northern Yemen, sort of a dialogue that GPEI had together with other international health partners with the local authorities convened in Yemen, in Jordan, in fact, a couple of months back, and the focus of that dialogue was exploring possibility of carrying out polio vaccination as part of overall integrated health services approach. There is plan to offer 2 polio vaccine doses to children in northern Yemen during the first half of 2025. But as we speak now, this remains a plan, and fingers crossed that it is executed and implemented. I also want to mention that the surveillance in northern Yemen has also been a bit of a concern, especially when it comes to the shipment of specimens from acute flaccid paralysis cases to the regional reference labs for testing for polioviruses. That hasn't really happened since June, which means a number of samples are sort of stuck in that part. And once those are shipped and tested, we may see a sudden surge in the number of polio cases from this particular geography, which actually would not be a surprise because we know the population immunity against polio is quite low in this region. And last but not the least, I think you might have heard about the outbreak in Gaza, the CVD-PV2 outbreak that was reported just after mid-year 2024, was responded quite well with 2 immunization rounds between end of August and end of October, each reaching close to 600,000 children and reported coverage of more than 80%. It was quite a well implemented, organized, coordinated response that was implemented under a humanitarian pause. But yet these situations really indicate ongoing significant challenges. Next slide. Now, with all these recent developments and contexts in view, the Polio Oversight Board actually has come up with revised timelines for both Goal 1 and Goal 2. The earlier timelines were alluded to by Rocio in the initial part of this presentation. So for Goal 1, which is interruption of wild poliovirus 1 transmission in the 2 endemic countries, is now aimed for end of 2025, and giving another 2 years to certify that eradication through the certification process in place. For Goal 2, the timeline has been revised for interruption of CVD-PV2 transmission by end 2026 and providing more time until end of 2029 to certify the elimination of CVDPV2. Now, it's important to mention that this is a revision in the strategy timeline. The operational strategic tactics haven't really changed much, but there is increasing emphasis on finding local tailored solutions in terms of fine-tuning the strategies and operational tactics to stop the transmission of wild poliovirus and CVDPV2 in the areas that still are seeing intense transmission. Next slide. Now, this is my last slide, and just to mention that there is an ongoing work on updating the post-certification strategy. This strategy document has already been available and in place, but in the current context, it is being reviewed and updated, and this is a work in progress just to document what's the vision of GPEI and health partners for a time prospectively when we probably and hopefully have the end of wild poliovirus type 1 and CVDPV2. This strategy document is it's under revision and will be completed and presented to the World Health Assembly in 2026 for endorsement of the member states. It's quite a consultative process that is being carried out to review and update this document, taking on board several different experts and GPEI groups, but also partners and institutions beyond GPEI for a period when we'll probably have the end of wild polio and CVDPV. Now, the post-certification strategy, the key activities in that period would be bOPV cessation, but also dealing with CVDPV type 1 and 3, responding to any possible outbreaks, and also certification of elimination of those two CVDPVs in future. This would, of course, evolve as we move on, explore more, learn more lessons, and will be adjusted as required. So that's the end of my part, and back over to you, Rocio.
Thank you, Zubair. So I'll move now to the final section of this presentation, which is on the bOPV cessation planning and the current discussions on the policy framework. And so, as mentioned by Zubair, this sort of falls under the era of the post-certification strategy. And so some background on bOPV cessation is that bOPV cessation is planned to be a globally synchronized withdrawal of a bivalent oral polio vaccine, or bOPV, from routine immunization. In essence, this would mean that all countries would become IPV, or inactivated polio vaccine, using countries. And so sort of under current projections, this would be anticipated to happen in 2030. And so to preface sort of the why OPVs must stop being used eventually, is that sort of to achieve global polio eradication, poliovirus must be removed from populations everywhere, including the Sabin viruses contained in OPVs. And so sort of the first step in this process of a global OPV cessation was the 2016 trivalent to bivalent OPV switch. And so the next step in that process would be this eventual bOPV cessation, for which planning has just recently begun. And so in light of this, the bOPV cessation team, or BOCET for short, was created or was commissioned by the GPEI Strategic Committee. And the first meeting was last year in January of 2023. And this is to, again, coordinate the planning for a bOPV cessation. And so here's to just highlight that the discussions and the inputs to bOPV cessation planning come from various streams of work or data or information. And so to highlight, as mentioned on the tOPV to bOPV switch, a very important document are the lessons learned from the switch, which I've included a URL there to the full report that's now available online. So this is the lessons learned are definitely a very important and large input into the planning for now bOPV cessation. Then also mathematical modeling, epidemiological analyses, programmatic experience, operational feasibility also essential, and data from various clinical trials, all sort of culminating into feeding the discussions of polio expert opinion. And so the sort of membership of BOSET initially now includes polio experts and also involvement from different GPEI partners and key stakeholders, including from WHO, BMGF, PATH, UNICEF, CDC, and Gavi, and then also engagement with different mathematical modeling groups from KidRisk or from academic institutions such as Imperial College London and the London School of Hygiene and Tropical Medicine. And so in the next year in plans for BOSET, the next step sort of envisions to expand this engagement and BOSET membership to include regional participation and discussion, especially to feed into this very important stream of input into bOPV cessation planning that is sort of programmatic experience and operational feasibility. And so now to move on sort of the ongoing and primary discussion within BOSET right now, which is the cessation policy framework. So the framework can largely be divided into 3 sections, the first being guiding principles of cessation, second, the triggers, and finally, the enablers of success of bOPV cessation. So in this slide, I'll briefly define each one of them, and then the next slides I'll go one by one of which are the pillars in each one of these sections. And so the guiding principles, these are the basic ideas or rules that will explain or control how bOPV cessation will undergo. And this is sort of the ethical imperative to do so, primarily centering on the first do no harm principle. And so the status of these guiding principles is that they were agreed upon by SAGE in earlier this year in the March meeting. Second will be the triggers for bOPV cessation. So these are defined as the non-negotiable conditions that must be fulfilled prior to cessation. And so these were also agreed upon by SAGE more recently in the September meeting. And then the final category are the enablers of success for bOPV cessation. And by definition, these are going to be the requirements that, if achieved, will minimize the risk of cessation failure. So then to draw a contrast between the triggers and the enablers of success, the triggers to highlight are the must-haves, the sort of go, no-go items to be able to move into cessation, whereas the enablers of success are the should-haves. So again, the must-haves versus the should-haves. And so right now is the main focus of BOSET is to sort of deliberate on these enablers of success. So the status is ongoing. This is sort of also ongoing presentation from BOSET to the SAGE, and I'll go into more detail on this slide pertaining to enablers of success of more of the current status there. So first, going onto the guiding principles for bOPV cessation. As mentioned, these are already endorsed by SAGE earlier this year. So these can be divided into 4 main statements. So first is that the risks of failure to control CVD-PVs following bOPV cessation are expected to be similar to those following the switch in 2016. So again, here highlighting the importance of the lessons learned from the tOPV to bOPV switch feeding into the planning for bOPV cessation. Then number 2 is that the preparation and implementation of bOPV cessation must follow the first do no harm principle. In essence, at all cost, we must strive to avoid that bOPV cessation results in thousands of children paralyzed with CVD-PV as occurred after the tOPV to bOPV switch. So again, highlighting the importance of the lessons learned for the program. Number 3 is that it will be preferable to delay cessation and be fully prepared than to implement cessation hastily, risking failure. So for this item number 3, it's where the triggers and the enablers of success are going to sort of inform a global readiness to be able to safely move into bOPV cessation. And then finally, number 4 is for the Global Polio Eradication Initiative, or GPEI leadership, to acknowledge that the planning and implementation of eventual bOPV cessation will require considerable program commitment, financial resources, and a partner engagement. So now moving into the second category of the policy framework, which are the triggers for bOPV cessation. Again, these are the must-haves, the sort of go, no-go. And these were endorsed by SAGE in September of 2024 in the most recent meeting. And so there are 5 statements here in the triggers, just to highlight that all 5 of these conditions must be met in order to be able to move forward with bOPV cessation as outlined in BOCIT and SAGE discussion. So I'll move through these quickly. So number 1 is that WPV1 must be certified as eradicated by the Global Certification Commission, or GCC. Number 2 is that the GCC must also certify the elimination of CVD-PV2. This will sort of have a twofold meaning. So first, it would be sort of a proof that OPV cessation is possible and programmatically feasible. And also this will ensure sort of outbreak response capacity post switch in the case of any emergence or transmission. So number 3 will be no persistent CVD-PV1 or 3 outbreaks in the previous 24-month period at the time of the decision to proceed with cessation. Note that here persistent circulation is defined as that lasting for more than 6 months. Number 4 is the availability of stockpiles of type-specific OPV, whether novel or Sabin, in sufficient quantity for any sort of vaccine needs in the post-cessation time. And then finally, number 5 is that all countries must have established at least a 2-dose IPV schedule in their routine immunization schedules for a minimum 2-year duration. So as Alejandro highlighted in prior slides, there are 33 countries remaining to add the 2nd dose of IPV into their schedules. And just to reiterate, this is a SAGE recommendation and should be considered urgently. And then just a subnote here is that in places where IPV coverage is considered suboptimal or underneath 80%, a risk-tiered approach for pre-cessation SIAs or supplementary immunization activities will be sort of planned out to further boost immunity. And here this sort of leads me into the next section and final portion of the policy framework, which are the enablers of success for bOPV cessation. Again, this is an ongoing topic and discussion within both BOCET and SAGE. And so I haven't detailed in all 4 categories, since again, this is an ongoing discussion and it's sort of not finalized yet to be able to present and bring forth. But largely the discussions are centering around 4 main topics. That's first, to attain and maintain high population immunity. Second is to ensure sufficient vaccine supply and stockpile. Third is for the verified absence of CVD-PVs. We must have sensitive, poliovirus surveillance. So again, an emphasis on quality and sensitive surveillance. And then finally, planning out for outbreak response capacity. And this would be in the case of any emergencies or detections of transmission post-cessation. And so I will sort of highlight in the first category, something that has come out from the most recent SAGE discussion, is that BOCET is sort of a big part of the discussion within high population immunity is on pre-cessation supplementary immunization activities. And so here, the SAGE did endorse that a modeling framework for country risk tiering should be conducted to sort of be able to plan for these pre-cessation SIAs. And this will be sort of fed in other factors by routine immunization coverage or historic CVD-PV transmission or emergencies, amongst other factors. And so this is a pending continued discussion in the next SAGE meeting in March 2025. And so that is all on bOPV cessation planning. But before we draw this to a close, I just wanted to highlight these recent SAGE recommendations related to the use of IPV, or inactivated polio vaccine, in routine immunization schedules. So earlier in the year in March, the SAGE reiterated that only countries at low risk of polio, as designated by each WHO region, that have attained high routine immunization coverage with at least 2 doses could consider transitioning to IPV-only schedules ahead of planned synchronized bOPV cessation. And so, sort of building on this, in the most recent meeting, SAGE sort of expanded by saying that sort of recognizing that there are some countries that could consider already moving to IPV-only schedules ahead of planned bOPV cessation based on per country risk factors, that the SAGE working group is sort of building a risk criteria framework to determine eligible countries that could safely consider transitioning to an IPV-only schedule. And so this work will sort of be presented and deliberated on in the next SAGE meeting in March of 2025. And so here I just wanted to state that these are sort of two different decoupled exercises, bOPV cessation, and then because bOPV cessation will plan to be globally synchronized at the time, and then this on another hand is sort of the per country consideration of moving to IPV only schedules, and so again this we're working on a WHO guidance for countries to have an understanding of the risk and benefits of this decision. And so moving now to conclude the presentation and all three sessions, first to preface that WHO is available to support and provide guidance to NITAGs on sort of all the items below or anything that has been presented today. And so first, again, to recall that the GPEI strategy has been revised and the timelines for both goals 1 and 2 have been extended. Then WHO at HQ, regional, and country level is available to support ministries of health and vaccine transitions, whether this is, again, sort of adding the second dose of IPV into routine immunization schedules in those countries that remain to do so, or applying for hexavalent vaccines, or again, transitioning to IPV-only schedules. Also putting an emphasis on the work being and to be conducted on enhancing surveillance quality. Also the importance of strengthening routine immunization and sort of the work that's being done on integration that was touched upon by Alejandro. And then also importantly, as presented in the last session, is sort of facilitating the planning for eventual bOPV cessation. And finally, just to emphasize that high risk areas are prioritized in program activities, sort of supporting the identification and targeted interventions in these high risk or underserved areas. And for now, that's all. I'll pass over to the chair, Mario, to close off. Thank you.
Thank you, Rocio, for this presentation. So if anyone has questions, you can just raise your hands or do it in the chat. We still have a couple of minutes left. I don't see any questions. Do you see questions, Luis?
Yeah, Rodzani has his hand up. And then Dr. Basma. Rodzani first.
Thank you, and thank you very, very much for this presentation. I think it's with respect to the last slides when we were finishing. I just wondered whether this has come up in an authorized meeting. The question about how one sees and assesses the risk at national level as opposed to regional level. So I was just thinking, if your chart, in theory, and you've got a population of 13.5 million, if assuming that you've got a certain vaccine coverage that you can accept as being good enough for a switch, but then suddenly because of conflicts in neighboring Sudan and 4 million people move across with an unknown vaccine coverage in them, it changes and dilutes your own vaccine coverage in your country. So we need, especially in areas like in Africa where the borders are porous and where there's been conflict, to understand what a regional risk profile looks like than thinking of it nationally. And I give this as an example of South Africa. South Africa has been using IPV with 3 and then 4 doses for the last more than a decade now. But the reason to stick with OPV included still has had to do more with what we see as a risk due to movement of people within the region, in and out of South Africa, looks like, and what the impact of that is in changing the national risk profile. Could you comment on that, on a regional outlook as opposed to NITEC and national outlook. Thanks.
Rocio,
Hi.
do you want to address this before we take the second question?
Yeah, sure. I can take this question. Thank you so much. That's a great question. And actually for the mathematical modeling work, this is something that is feeding into the models, sort of migration patterns. So this specifically, for example, I think you were referring specifically to maybe this slide of speaking of this work for the per country analysis of moving into IPV only schedules. And so while this is a per country analysis rather than regional analysis, migration patterns are considered and included in this framework. And so, as I mentioned, these results and the discussion will be discussed in the next SAGE meeting. So hopefully by March or April of next year, there can be some more feedback on this. Thank you.
Dr. Basma?
Thank you. Thank you for this presentation. Actually, my question is, again, on the same slide, that there is a recommendation from SAGE to shift into IPV only schedule. And we are in a countries that is low risk for polio transmission, but unfortunately, we are still surrounded with countries still endemic with polio, and the risk of polio importation is always there. But if we have high vaccination coverage, I mean, how do we classify our risks to be low, and how can we shift directly to IPV complete schedule if we are following the sequential schedule now?
So thank you very much. So this framework is not only taking into consideration the routine immunization coverage, although this is, one of the main inputs, but it's also taking into consideration sort of historical sort of in-country emergences or importations, or also sort of how long maybe transmission was sustained. And then also, as I mentioned in the prior question, migration patterns, especially from both endemic countries, this would be pertaining to WPV1, are all factors that are being fed into this modeling exercise. And so again, in the next SAGE meeting after deliberations, this is sort of the framework that will be brought forward to then be able to discuss with countries specifically on, to understand the risks and benefits to then proceed with this decision. I hope that answers the question.
Thank you.
Yeah, I think there are no more hands raised, right, Luis?
No more questions also on the chat. There was one, but Alejandro replied regarding the vaccine recommended for zero dose children above 6 years of age. As a reminder, there was also an EXA webinar, a GNN EXA webinar that we did earlier in the year, and I can also recirculate the presentation that was given during the EXA webinar. And just a small correction to what Mario said at the beginning of the webinar. We did circulate the off-label survey, and it is one reply by country. So we hope to have as many countries as possible in our replies, but only one reply needed by country. So I don't see any other questions. The recording, the presentation will be circulated, and you can contact the speakers if you have remaining questions. And then we'll give you back half an hour of your time if you don't have any other questions. So thank you, everyone. Thank you, Rocio. Thank you, Alejandro. Thank you, Diana and Rudi, for the preparation.
Hi.
Thank you.
Thank you, everyone. Goodbye.
Thank you.
Thank you.
Thank you very much.
Thank
Bye.
you.
Bye.
Great to see you all.
Thank you and goodbye.